You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 7th, 2025. This week, some listener feedback on asymptomatic aortic stenosis, TAVR versus SAVR, coronary artery calcium, and revascularization for patients with ischemic left ventricular dysfunction. Two listener feedback comments today. The first is that on February 14th, I misspoke about the NOAA and Artesia trials. I said that the NOAA trial was rivaroxaban versus placebo, but of course NOAA was edoxaban versus placebo. Two listeners have written to me about that, and I will change the transcript, and sorry for the mistake, I was just going too fast. The second listener feedback is worth expanding a bit based on some new papers published in the Journal American College of Cardiology, and this is in regard to the treatment of patients with asymptomatic aortic stenosis. I received a note this week from a doctor for whom I have the highest respect for. He was, in fact, one of my mentors at Indiana, and he was actually instrumental in me choosing cardiology as a career. I offer this to you because I put this person in the 99th percentile of doctors I have worked with in the past 3 decades. My mentor did not agree with my opposition to operating on asymptomatic patients with severe AS. I felt the evidentiary support for this was weak, that severe aortic stenosis is not even simple to diagnose on echo, and a change in practice pattern would lead to even more low-risk patients getting transcatheter aortic valve replacement or TAVR. My mentor wrote, quote, "While I've been a loyal listener to This Week in Cardiology, I was disappointed with your view on the timing of aortic valve intervention in patients with asymptomatic aortic stenosis." He did agree with several of my points, the first being that I said that the asymptomatic patient with aortic stenosis is often not asymptomatic when a physician takes a careful history. In his experience, when patients are carefully questioned who have aortic valve areas of less than 0.75 centimeters squared or less are actually frequently symptomatic. My mentor also worried, like I did, that increasing the indications for aortic valve replacement to asymptomatic patients, particularly using TAVR, will result in an explosion of TAVR procedures. He also agreed that the consequences of AV block requiring pacemaker implantation after TAVR is an under-recognized issue. But he disagreed with several of my points, and here's a list of what he disagreed with. First, he writes, secondary cardiac damage impacts adversely on the prognosis of patients with AS and starts before the onset of symptoms or impaired LV ejection fraction. Second, there is now accumulating clinical evidence supporting the earlier timing of AVR with asymptomatic severe AS and those with upstream cardiac damage secondary to the aortic stenosis. Third, the use of CMR to evaluate for late gadolinium enhancement may help to identify higher risk patients who would benefit from earlier intervention. Fourth, several studies, for example, DAN-AVR, are excluding patients with very severe AS, that is a Vmax greater than 5 meters per second. Fifth, unless symptomatic patients are followed closely, the LV remodeling may lead to upstream sequelae, including MR, left atrial enlargement, atrial fibrillation, which is a difficult condition to treat in the presence of severe AS, obviously, and pulmonary hypertension, and RV dilatation and TR. So in sum, my mentor writes that AS is not a benign disease. In a large U.S. database of almost 600,000 adults from 24 hospitals, the untreated mortality of patients with mild AS was 24%, for moderate AS, 34%, and for severe AS, 45%. An Australian population database of over 25,000 patients showed similar results. My mentor concludes by noting that he and I grew up under the mentorship of Dr. Charles Fish, who recommended a conservative approach to the management of cardiac patients. And in general, this approach has served me well during my career. However, I have changed my opinion with regards to early intervention for severe symptomatic AS. Given the availability of excellent cardiac surgeons or interventional cardiologists, consideration of earlier intervention seems warranted. Okay, my friends, I offer this criticism because it comes from such a skilled and experienced physician. I think there are many good points made. However, I still feel that the evidentiary support for a blanket recommendation for the treatment of all patients with asymptomatic severe AS is quite weak. However, as I said on the podcast, I think that it's really important for physicians to take the time with patients to tease out symptoms and then to align care with those patients' goals. But I really push back against a blanket recommendation because I worry that TAVR will be expanded to even more low-risk patients, and in fact, I'm going to show you some papers along those lines. So the next topic actually is regarding the overuse of TAVR, especially in young patients. I want to make note of two recently published manuscripts in JACC in this TAVR versus SAVR space. The first paper is an updated meta-analysis of RCTs of TAVR versus SAVR in low-risk patients. The first author was Robin Reddy. Now, this attempt was to pool trials to assess outcomes because new trials have been published and older low-risk trials have now reported longer-term follow-up. This meta-analysis included Partner 3, Evolute Low Risk, UK TAVI, Notion, Dedicate, and Notion 2. The main finding, published in JACC, was that about 5,300 lower-risk patients were randomized 1-to-1 to TAVR versus SAVR, and at 5 years, in the pooled survival analysis of a reconstructed time-to-event analysis, TAVR was associated with a 20% reduction in the hazard of all-cause death. The hazard ratio is 0.80 with confidence intervals from 0.66 to 0.97, so statistically significant. And TAVR was also associated with a 19% reduction in the hazard of all-cause death or disabling stroke. Here, the hazard ratio 0.81 with confidence intervals going from 0.68 to 0.96, so again, statistically significant compared with SAVR. The meta-analysis found no difference in stroke, however. The authors concluded, quote, in lower-risk patients, TAVR was associated with a reduced hazard of death and death or disabling stroke compared with SAVR, while rates of stroke were equivalent. However, even they note in the next sentence in the abstract, quote, most patients have not yet undergone 5-year follow-up, and so these findings may change as further long-term data become available. The present data are informative for lower-risk patients and treating clinicians, but further randomized trials and longer-term follow-up are required, particularly in younger patients. So my comments on this meta-analysis in JACC is that it's a troubling study. Though the authors offer the duration of follow-up caveats, there are many other caveats. First, at least 2 of the included trials included intermediate-risk patients. And here is an age-old problem with meta-analyses because you simply have to be cautious about what studies are included. Second issue was that the authors did not have individual patient-level data, instead used a procedure with software to extract the coordinates of the published Kaplan-Meier survival curves, along with the information on the number of patients at risk and the total number of events. And the aim of this is to reconstruct the underlying time-to-event date for each treatment group. They then use these reconstructed data to generate a pooled estimate of survival probabilities and hazard ratios. While this software-heavy technique has been published and it has been used, there are substantial limitations of this technique, many of which are beyond the scope of my methodological knowledge. JACC does offer a nice accompanying editorial from Joshua Wallach and David Cohen, and they describe some of these limitations. I guess my point would be that if you had trials with similar duration of follow-up, similar patients, and you could make an individual patient analysis, you could simply pool the data rather than doing these extrapolating things from graphs from PDFs. Now, the editorialists, Wallach and Cohen, also emphasized the duration of follow-up issue, noting that only 2 trials, representing less than 25% of the cohort, contributing data through year 5. and they recommend that the authors continue to update the meta-analysis. But I wonder, well, okay, that's fine, but why even publish such a limited meta-analysis now? The fact that it had a positive result for TAVR makes me wonder. Now, another paper I found via a reference in this meta-analysis is even more sobering, super sobering. This reference went to a presentation at New York Valve conferences by Dr. Mayra Guerrero, and this was a national inpatient sample that she presented. And sit down for this. In patients aged 50 to 64 years old who had symptomatic severe aortic stenosis, TAVR was the mode of aortic valve replacement for 42% of patients in 2020, and that was increased from 14.2% in 2016. And the authors of the meta-analysis write, quote, "This is not an approach currently supported by the available randomized data, including their analysis, and before TAVR is adopted for very young patients, dedicated randomized trials would need to be conducted with long-term, that is 10-year follow-up, and consideration given to the lifetime management of these patients." And of course, this is my main point that I have been talking about on this podcast for years regarding TAVR. TAVR is amazing. It's a great innovation. But the momentum and application of TAVR to very young and lower risk patients is not evidence-based, nor is it wise. That 41% of AVR procedures were TAVR in patients aged 50 to 64 is ludicrous. This is crazy, but this is what happens in medicine. All right, next topic is CAC, coronary artery calcium. We are back again talking about the 40-year-old imaging test without outcomes data. Because, why? Because JAMA has published an RCT of using CAC to guide preventive therapy. And this paper made the rounds on social media. CAC has many proponents who are active on social media. So this was from Australia. Australian authors asked the question of whether combining CAC score with a preventive strategy can be used to reduce plaque progression in intermediate risk patients who have a family history of coronary disease. It was a prospective, randomized, but open-label trial done in 7 hospitals. The patients were asymptomatic adults who had a first-degree relative with coronary artery disease before age 60. So that's a good patient population because patients with a family history are worried. The authors screened around 1,100 patients who had this family history. Now, patients could not have a statin indication such as a very high LDL, and all patients in this trial were statin naive. And those who had a CAC of 0 or CAC of 400 were excluded. They ended up randomizing about 450 patients to either a CAC score informed group, that was the active treatment group, versus standard Australian care. Now, the mean CAC score in both groups were 64 to 72. The average pooled cohort equation risk, 10-year risk, was 6.6 to 7.2. So basically, this trial studied patients just below the ACC-AHA threshold for statins, which is 7.5%. So the CAC-informed group was nurse-led, in which the participants had their CAC images shown or used to communicate about heart disease. And importantly, after all this education, everyone in the intervention group started lipid-lowering therapy, most often with a statin. The usual care group had standard education from their primary care clinicians about, CAD prevention, and the GP was blinded to the CAC score. And none of these patients were recommended for statins initially, and a handful crossed over and took statins. But basically, it was a statin group and a non-statin group. Now, the primary endpoint of this trial was, quote, total plaque volume, with a further analysis for calcified and non-calcified plaque volume. That was done on a CCTA done at 3 years. And after 5 years of follow-up, the CAC score-informed group showed significantly greater reductions in LDL cholesterol. Of course it did, because it was statin versus non-statins. Now, the primary outcome of total plaque progression was significantly lower in the CAC score informed group compared to usual care. And I could give you the numbers in millimeters cubed, but I don't know what it means. It does seem like a small difference, but it was statistically significant, as were secondary outcomes such as non-calcified plaque progression and fibrophagy and necrotic core plaque volume. Again, the numbers don't mean anything to me, but these were significantly lower in the active arm. And the plaque progression differences remain significant after adjusting for baseline variables. And the effect of CAC score informed strategy was particularly pronounced in patients with scores greater than 100. And the authors enthusiastically wrote that, quote, "These data support the use of CAC score to assist intensive preventive strategies in intermediate risk patients." And there were 2 editorials accompanying the manuscript that were supportive. Of course there were. My comments are that I don't agree. In fact, I strongly disagree. While I nearly always laud those who take the time to randomize, the amount we can take from this trial is very small. The trialists themselves tell us about serious limitations. For instance, 13% of patients were excluded from the final analysis due to poor image quality or technical limitations, and given the small differences in the surrogate outcome, that could end up being a lot. But of course, I don't know enough about plaque progressions images on CCTA to say. The authors also tell us that plaque progression is a surrogate endpoint, and I would emphasize, as I did last week, that if previous studies suggest that MI, myocardial infarction, is a poor surrogate for CV death, then surely plaque progression is a long way from telling us anything important clinically. I am not an imager, but the little reading I've done suggests that characterization of plaque components on CTA can be challenging. What's more, even if you accept the surrogacy of an image on a CT scan, I don't, but if you do, this is really a study of a strategy of statin use versus non-statin use. Oh, I'm not sure how the CAC score even figures in. Not only that, but patients in the open-label trial and the nurse intervention group could have behaved differently. For instance, they might have lived in a more healthy way based on the nurse intervention and the knowledge that they were in the active arm of a trial. Of course, the trial ends up with less than 200 patients in each arm. There's no power to detect any clinical outcomes, yet proponents can use a short-duration, surrogate, positive JAMA study to further promote CAC scanning. I remain steadfast in my opposition to this test. Now, thankfully, JAMA did include one related article wherein the Northwestern University authors outline 3 areas where CAC scans should not be used. One is in young patients, because, of course, in a young person, a CAC 0 is not that reassuring. Another time to avoid CAC scores in older patients where calcification is common and the patient already satisfies statin use based on the PCE. And the third scenario is repeating a CAC scan, which should have really no role. And again, these are such obvious things to me, but these are all scenarios where I see patients getting CAC scans in clinical practice. All right, the final topic today has to do with CABG, PCI, or meds for ischemic left ventricular dysfunction. And this was stimulated by a European Heart Journal, has published a very interesting paper from the author of the STITCH trial and then STITCH's follow-up and the revived BCIS trial. Both of these were relatively shocking trials because I can't imagine that we here in Louisville would have managed to randomize even one patient in either of these trials. Basically, the authors of this meta-analysis took individual patient data and did cross-trial comparisons. And they ended up with 3 main comparisons. The first was medical therapy in Revived versus medical therapy in the STITCHES trial. The second is medical therapy in Revived versus the CABG arm of STITCHES. And the third is the PCI arm of Revived versus the CABG arm of STITCHES. Now, it is super important to note here that neither trial was CABG or PCI versus meds. It actually was CABG plus meds versus meds alone in STITCH and STITCHES, and it was PCI plus meds versus meds alone in Revived. In other words, PCI and CABG were add-ons to medical therapy for these patients with HFrEF who happen to have severe coronary disease. Now, a brief review of the trials. First, Stitch. Stitch, CABG versus medical therapy, or CABG plus meds versus meds alone in 1,200 patients with an EF less than 35% and had coronary disease amenable to CABG. The key point for this paper and this podcast is that Stitch randomized patients between 2002 and 2007, so a long time ago. The 5-year results of Stitch, which were the primary analysis, were that a primary outcome of death from any cause occurred in 41% of patients in the medical arm, 36% in the CABG arm. That hazard ratio of 0.86 had confidence intervals that went from 0.72 to 1.04. So the main results of Stitch, the 5-year results, were not significantly different. The difference in death was only 26 deaths in a trial of 1,200 people. Now, to their credit, the Stitch authors continued a 10-year extension of Stitch, which was called the Stitches trial. Now, the effect size at 10 years versus the CABG arm and the medicine arm were nearly identical at 0.84. This is a 16% reduction in the CABG plus meds arm. But because there were more deaths, now it was 59% versus 66%, the result reached statistical significance with a confidence interval going from 0.73 to 0.97, a p-value of 0.02. Though we must remember the 5-year results were the predetermined primary analysis. Now, even at 10 years, in 1,200 patients, the difference in deaths was only 39 deaths. Now, the revived BCIS trial, I've discussed this many times, but very briefly, this enrolled similar patients as Stitches. These patients had a low EF, less than 35%. They had to have multivessel coronary disease that was amenable to PCI, and in Revive, they had to have viability in multiple segments. And the trial compared PCI plus medical therapy to medical therapy alone, and over 3.5 years, the revived authors found no significant difference in the primary endpoint of death or heart failure hospitalizations. Death, too, was not different. In fact, absolutely nothing was different in Revive. Not EF, not quality of life, no subgroup, no sub-analysis has been published that shows that PCI improved over medical therapy. Now, as I said when I introduced this topic, it's hard to imagine randomizing any patient into any of these trials. I ask you now to pause the treadmill or shift to an easier gear on a bike or stop the bike and close your eyes and imagine the angiogram of one of these patients. See the image of severe multivessel coronary disease and a bad ventricle. Now, imagine that patient with that angiogram putting into an arm with just tablets, leaving all those high-grade coronary stenosis and all the resulting ischemia. My friends, that would never happen in Louisville. Such a patient would have a hotline to stents or bypass, depending on the anatomy or the mood or the busyness of the operators. My point is that medical therapy did amazing in these trials. Yet neither of these trials have gained much popularity, at least here in my area of the United States. Now, the most recent study in the European Heart Journal combined these trials using actual source data. This is the clinical report forms with an idea of comparing outcomes of patients with medical therapy alone in Stitches and Revived, and to estimate whether CABG would provide any incremental benefit over modern medical therapy as used in Revived, and of course, thirdly, to compare the outcomes between CABG and PCI. The primary outcome of this pooled analysis was the composite of all-cause death or hospitalization for heart failure. Secondary outcomes included the individual components of the primary outcome, but they also looked at CV death and MI. Okay, here we go. The medical therapy of arm in Stitches, the older trial, was the reference for the between-trial comparisons. Keep in mind that even though this was RCT data, the comparisons are observational because they're between trial. The groups were different. For instance, the mean age of patients in Revived was nearly 10 years older than Stitch, so they had to do adjustments, just as is done with any non-random comparison studies. Now, the meta-analysis had a total of 1,900 patients in the two trials, Stitches and Revived. The mean age combined was 63 years. The mean EF was terrible at 27%. Now, enrollment to Revived was from 40 sites. That was exclusively in the UK, whereas participants in Stitches were enrolled from 127 sites in 26 countries. Follow-up was a lot different. 10-year in Stitches, and it's only been 3.5 years in Revived. The primary outcome of death or heart failure hospitalization in the first comparison was of the two medical therapy arms, and it was 40% less in Revived, hazard ratio 0.60 with tight confidence intervals, and in the propensity-matched cohort, the hazard ratio was even lower with medical therapy of Revived versus medical therapy of Stitches. Here, it was 64% lower in the medical therapy of Revived. Now, if you compare the reference arm of medical therapy in Stitches to CABG, the hazard ratio was 0.8. If you compared to PCI in Revived, it was 0.59. In other words, CABG was 20% better than medical therapy in Stitches, and the PCI in Revived arm was 41% better than the medical therapy in Stitches. I just told you, though, that medical therapy in Revived was also 40% better than the medical therapy in Stitches. Now, finally, in the propensity-matched group, medical therapy in Revived was 38% better than CABG. Let me say that again. The medical therapy in Revived, the contemporary medical therapy, was 38% better than CABG in Stitches. And in the PCI arm of Revived versus CABG, PCI was 39% better. And similar or directionally similar hazard ratios were seen with all-cause death and CV death. And the authors of this meta-analysis and this cross-trial comparison study concluded that patients with ischemic cardiomyopathy receiving medical therapy in Revived had better outcomes than those in Stitches with or without CABG surgery. They then write that further trials comparing CABG PCI medical therapy in this population are warranted. My comments, we have to be super careful with this. It's a well-done, careful analysis on paper. The patients look similar. For instance, they all had bad coronary disease and all had bad ventricles, but the trials recruited at different times and in different geographies. These are actually different patients. Nonetheless, the patients in the medical arm of Revive, which is far more contemporary than Stitches, yet still started recruiting before ARNIs and SGLT2 inhibitors were available, had much lower rates of death, heart failure, and CV death than either arm of Stitches, whether it's medical or CABG. The medical therapy in Revived beat medical therapy in Stitches and CABG in Stitches. PCI in Revived also looked better than CABG in Stitches. Now, I think the finding we can be most confident in this study is there's been an improvement in medical therapy over time for patients with HFrEF and coronary disease. We have new drugs, and we probably have a more aggressive mindset when it comes to using medical therapy. Though some of the better outcomes could be explained by the fact that patients with mitral valve disease were allowed in Stitches, but were excluded from Revive. So Revive may have had healthier patients, even though they were older. The second finding that is striking is that modern medical therapy in Revive was also much better than CABG, though we have to highlight the caveats of non-random comparisons of two trials. I am somewhat confident in this finding, though, because if you think about priors, put your Bayesian hats on, when you go back, you have 3 of the 4 CABG versus MEDS trials in the 1980s were negative. And in the 1980s, there was like 0 medical therapy. So I apologize in advance to my surgical colleagues, but the evidence underpinning CABG for multivessel, stable coronary disease over medicines is not strong. So, at worst, the superiority of medicines in Revived versus CABG in Stitches is hypothesis-generating, and I think this data warrants a modern-day repeat of the CAST trial in patients with HFrEF and coronary disease. The authors of this paper tell us that there will be such a study comparing bypass and medicines, but this study will be single center. And I really do wonder how meds will compare to coronary bypass in this contemporary era. Now, the result that I am least confident about in this paper is the PCI superiority of CABG, given that there were differences in baseline characteristics, different geographies, different time frames, though this too needs to be compared head-to-head, and the authors of this paper describe a Stitch 3 consortium wherein the two modes of revascularization will be compared. My prediction, though, going forward is that in the next 5 to 10 years, the young cardiologist will come to see the value of medical therapy much more so than people of my generation have. All right, finally, I want to do a very brief preview for next week. I've been seeing a lot of posts on social media and some articles on the issue of orthopedic problems in cardiologists. In fact, last winter, I myself had cervical fusion surgery because I had arm problems. My arm is fine, and I'm fine, and there's no issues. But literally none of these posts or articles question the causal relationship between being a cardiologist and having orthopedic injuries. It's just assumed that wearing lead, leaning over a table for a year, causes bone and joint problems. But the level of evidence for causation, I think, would make Bradford Hill turn in his grave. I have found, and I've looked only briefly, mostly surveys. Surveys. What's a survey? A survey is a list of anecdotes. It's as if 50 to 60-year-old cardiologists don't do anything else in their life to cause stress on their necks and backs. So next week, I will explore the evidence and we'll just do a more formal assessment. But the reason why I bring this up is because I consider it an exercise in causal inference and the judging of epidemiologic evidence. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. And as always, if you don't agree with something I say, teach me something, write to me, and if it's really good, I'll bring it up in listener feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.